Hi everyone, our subject today is alkalemia in pediatrics. Basics. Alkalemia is a serum pH above 7.45. The term alkalosis refers to the process resulting in excess total body bicarbonate, HCO3, or deficit of total body hydrogen. The disorder may be acute or chronic, primarily metabolic or primarily respiratory, or occur as part of a mixed acid-base disorder. History. The history should inquire about underlying medical problems and medication use, as well as potential losses of GI fluid like vomiting, diarrhea, nasogastric drainage. The diet history should inquire about the possibility of ingestion of natural licorice. Prenatal history of polyhydramnion and history of prematurity may suggest a primary renal hypokalemic syndrome like Bartter syndrome. Older children should be asked about use of chewing tobacco because some brands may contain an acid with the mineralocorticoid effect. If the etiology of a metabolic alkalosis is not clear from the history and physical examination, a spot urine chloride test will aid in the diagnosis. How to approach the child with alkalemia after performing history and physical examination? Patient need blood gas analysis, electrolyte, creatinine with the spot urine chloride. If the result PCO2 less than 40, this is respiratory alkalosis. Differential diagnosis: psychogenic, anxiety, fever, sepsis, high altitude, pneumonia, pulmonary emboli, congestive heart failure with hypoxemia, CNS disorder, liver failure, salicylate, other medication, and mechanical ventilation. If the PCO2 more than 40, this is metabolic alkalosis. Obtain spot urine chloride. If the urine chloride less than 10 milliequivalent per liter, differential diagnosis: vomiting, pyloric stenosis, nasogastric drainage, diuretics, prolonged use, congenital chloride losing diarrhea, laxative abuse, low chloride intake like in cystic fibrosis, resolving chronic hypercapnia, and exogenous alkali. If the result of urine chloride more than 10 milliequivalent per liter, is there hypertension? If it is no, differential diagnosis: Bartter syndrome, Gentleman syndrome, diuretic, recent use, magnesium depletion. If there is hypertension, differential diagnosis: excess mineralocorticoid effect, primary aldosteronism, renal artery stenosis, renal secreting tumor, Cushing syndrome, congenital adrenal hyperplasia, 17-hydroxylase deficiency and 11-beta hydroxylase deficiency, licorice or chewing tobacco, and Liddle syndrome. The pH reflecting extracellular free hydrogen ions concentration. Partial pressure of CO2 and plasma HCO3 level are considered in the clinical acid-base disorder. Their relationship is described by the modified version of the Henderson-Hasselbalch equation: hydrogen equal to 24 multiplied by partial pressure CO2 over the carbonate. In response to an increased pH, the body normally attempts to decrease total serum carbonate, renal compensation, and increase partial pressure CO2, respiratory compensation. Respiratory alkalosis occur when a respiratory decrease in the PCO2 cause an increase in the pH to greater than 7.45. Hyperventilation of various causes is the most common etiology. Tachypnea is often obvious initially. In chronic respiratory alkalosis, the respiratory rate may approach normal with the patient taking deeper breathing. Metabolic alkalosis occur when a primary increase in extracellular bicarbonate cause a rise in the pH above 7.45. The etiology may be loss of hydrogen ion, gain of bicarbonate, or loss of extracellular fluid, with the chloride losses exceeding carbonate losses. Factors that prevent renal excretion of carbonate, renal failure, volume depletion, profound hypokalemia must be present to maintain a metabolic alkalosis. Volume depletion results in aldosterone-mediated sodium retention in exchange for potassium and hydrogen secretion, which maintains an alkalosis, contraction alkalosis, with the paradoxical aciduria. Hypokalemia is a stimulus for additional renal hydrogen secretion. The loss of hydrochloric acid due to vomiting or nasogastric fluid drainage leads to increased gastric HCl production, which is combined by systemic carbonate production. The alkalosis is further maintained by volume depletion that results in aldosterone-mediated renal absorption of sodium in exchange for hydrogen and potassium secretion. High urinary chloride losses, sodium chloride, occur shortly after beginning diuretic therapy. Urinary chloride losses are minimized with the prolonged therapy because of chloride depletion and subsequent volume contraction. The volume contraction results in aldosterone-mediated sodium and closely linked chloride reabsorption and hydrogen ion secretion. In congenital chloride wasting diarrhea, a rare inherited disorder, a defect of the normal chloride for carbonate exchange in the ileum and colon lead to increased GI losses of chloride and subsequent metabolic alkalosis. Infants with cystic fibrosis require more sodium chloride than is contained in usual formula or breast milk. High losses of sodium chloride in sweat that are not countered by dietary intake can cause volume contraction and mild metabolic alkalosis. Rapid recovery from compensated chronic respiratory acidosis can cause post-hypercapnic metabolic alkalosis. This scenario is most likely to occur in infants with bronchopulmonary dysplasia who have experienced sodium chloride losses and volume depletion from diuretic use. After correction of the hypercapnia and despite normalization of the pH, renal carbonate reabsorption is favored until volume and chloride depletion is corrected. Ingestion of exogenous source of alkali, citrate, acetate, lactate, carbonate is occasionally sufficient to generate metabolic alkalosis. Excessive transfusion with the citrated blood or plasmonate containing acetate are other possible causes. High level of urinary chloride indicate some impairment of urinary reabsorption of chloride. The presence or absence of hypertension can help clarify the diagnosis. Mineralocorticoid excess typically result in volume expansion and hypertension. Congenital adrenal hyperplasia with deficiency of 11-hydroxylase or 17-hydroxylase enzyme result in level of deoxycorticosterone, an aldosterone precursor, high enough to exert a significant mineralocorticoid effect. Natural licorice and some chewing tobacco have glyceric acid that create a mineralocorticoid effect. Bartter syndrome is a rare renal tubular disorder characterized by hypokalemic metabolic alkalosis, urinary chloride wasting, increased plasma renin and aldosterone level, and normal to low blood pressure. Children exhibit failure to thrive, short stature, polyuria, polydipsia, and tendency to get dehydrated. Gentleman syndrome is a similar but more benign tubular disorder characterized by hypokalemia and urinary magnesium wasting. Children with this syndrome exhibit short stature and rare prone to febrile seizure and hypomagnesic tetanic episode. The two disorders can be distinguished by urinary calcium level, which are high in Bartter syndrome and low in Gentleman syndrome. Thank you for your listening.